Good evening, everybody. Welcome to tonight's Trans Topics Workshop. We're very glad that you could all join us here tonight, and we hope you'll be able to join us for future seminars as well, including our next workshop, which is Changing Your Name in Pennsylvania, which is next Tuesday at 7:30, given by yours truly. So I expect everybody to show up and be engaged. We also encourage you all to follow us on social media and to join our email list, so that you'll always be aware of what's going on and what we're working on. And I will be posting links to those in our chat here in just a few moments. We are offering these seminars free of charge to our community, and we're able to do that, frankly, through the generous donations of people in our community. So if you would like to donate to support our work, you may do so by texting the word GIVE to 844-909-2164. That is also right over my shoulder here. Mm-hmm. And you can text that at any time, and any donation of any amount is always appreciated. As a courtesy to others and also to ensure confidentiality for the people attending the seminar, we have muted your microphones and we have muted your video. That being said, we do want to make sure that this event is interactive as possible. So you can ask questions and make comments in the chat at any time, and I'll be monitoring that window and relay questions to Dr. Wahhab so that they can answer them. So let's just do a quick test to make sure that everybody's chat is in fact working. So just take a second or two and let us know what your favorite type of food is. For example, I'm a real sucker for Italian food, in particular Northern Italian food. So we've got Mexican from Emma. Let's see here, steak from Christine, nothing better than a good steak. Thai, hamburgers, pizza, seafood, more Thai, more steak. Pho, excellent. Mm-hmm. Tacos, peanut butter. Okay, that's just weird. Ramen, more Italian, Mexican. And Rachel says hi, and she likes chili, biscuits, and gravy, and more hamburgers. So it looks like everybody's chat is working, so thank you for that. So now let me just take a moment to introduce our guest speaker for the evening, Dr. Samina Wahhab. Dr. Wahhab has a Bachelor of Science degree from American University in Washington, D.C. She subsequently received her medical degree from Hahnemann University in Philadelphia, and she completed her residency right here locally in the Lehigh Valley at Lehigh Valley Hospital. And she liked it so much in Allentown, she decided to stay and set up her own practice in 2001. She was the first and only female plastic surgeon in the area. She completed her board certification in 2003, and she is in fact certified by the American Board of Plastic Surgery, and she has a special interest in serving the transgender community. And tonight she will be talking about top surgery for trans women, and we do hope to have her back to talk about trans surgery, top surgery for trans guys as well in the future. So please welcome Dr. Wahhab.
Hi, everyone. I hope everyone is doing well tonight, staying healthy, staying safe, staying warm with all the craziness in the weather as well. So I was asked to talk to you all about top surgery, specifically for trans women. I do both. So rather than do a formal fancy PowerPoint presentation, I wanted to make this a little more informal. And so I'm basically going to take you through a consult, as I would with any patient who was in my office, and then, of course, open it out to questions. A few things that are particular to trans women. One is the insurance coverage. And what I have found is that for trans men, insurance is much more likely to cover for mastectomies. For trans women, insurance is less likely to cover for breast augmentation. And I've run across this, and every time I get a rejection, I call and I do what we call an appeal or a peer-to-peer review where I talk to the physician. And more often than not, the answer is if there is any sign of breast tissue development to the adolescent stage or greater, they're not going to approve it. And their reasoning behind that is that they feel that if there was a cisgender woman who had small breasts and was not developed to the size that she felt comfortable with in her body, they wouldn't approve that either. So that's definitely one thing to be aware of. And unfortunately, when an insurance company is called and says, and you say, I have this diagnosis and I want to have a breast augmentation, they'll look at their policy and say, oh, yes, we cover that. We cover that at 100%. But they don't tell you what their criteria are unless you dive deeper into that. And usually they don't even tell us until we send it in, and each insurance company is going to be different. Someone just popped up. How large is that? And do they consider body size percentage? They don't. They go by the Tanner stages, which has to do with if there's development of the areola, if there's breast tissue, if there's any ptosis. So it's not necessarily something that's proportionate to your body size. It all goes by Tanner stages of puberty development. And right, HRT does develop some breast tissue. So that's where sort of the glitch comes in, is if you have a great response to HRT, you feel good about it, that's great, you have breast tissue, but then your insurance may turn around and say, we won't cover the augmentation. So then that ends up turning around to be an out-of-pocket cost. I don't know if that's going to change. I don't know if are there any advocacy groups out there that are working on this to try to help that. So that's one of the things that I think people need to be prepared about.
And so do you work on appeals and if we decide, if I decided I wanted to get top surgery and I could, I wanted to push back on my insurance company, you'll help us with that appeal process?
Yep. The first thing we have to do is what's called a peer-to-peer, which is where they have me on the phone with the medical director. The medical director will look over the initial letter, they will look over the pictures, and then they will tell me the reason why it was denied. And most of the time for breast augmentation, it's denied because there is already enough, what they consider a Tanner stage 2 or 3 breast development. They say that's enough.
And in terms of that, trans folks suffer from gender dysphoria, right? Is a way to alleviate gender dysphoria, which is a separate medical condition, right? Is there an opportunity to?
Correct. And I discussed that with them, and I have had medical directors turn around and say to me, well, if there's a cisgendered woman who's 5'10" and an A cup, she may be dysphoric about her body. That does not mean we're going to cover breast augmentation. Okay. After the peer-to-peer review, then it goes back to the patient having to file an appeal directly with the insurance company through letter writing and support. I haven't had anyone go through that process yet to see if it's actually effective. For other surgeries, when we have done that, it's very rare that it's been effective. I remember years ago a woman saying that she was going to go stand on the table naked in front of all these people and say, you've got to help me. And, it's not terribly effective.
So there's a question about, if you have asymmetrical breasts.
Right. So with and there was a question above that too from Emma. Comparison, the timing of puberty. There isn't really a way to push from that perspective. I almost feel like saying get your breast implants early before they develop, but then we don't know how it's going to all turn out once they do develop. Asymmetric breasts are not covered in cisgendered women. I get a lot of them. And unfortunately, that's not covered. Now, if you have one side that is completely not developed, perhaps they will consider covering at least that side as part of the gender dysphoria, non-development, did not get breast tissue, to puberty stage. But whenever I've tried to have any type of breast asymmetry covered, it is not, unless it's with something specific called Poland syndrome, which is a specific syndrome that can affect the development of not just breast tissue, but nipples and pectoralis muscle and the hands and fingers on that side. And so sometimes when someone has Poland syndrome, we can then put it through as a breast reconstruction. So I don't know then about getting breast augmentation. That was another question prior to starting hormone therapy. The plus side is that insurance will cover it. The downside is we don't know what size your breasts are going to develop to. and where anatomically, like if they're going to come out forward more or if there's going to be more drooping. So there is the chance then that doing the breast augmentation is going to interfere with what your development is going to look like cosmetically, because we don't know where the breast is going to grow. So we may end up with an implant with like a breast hanging off of it a little bit or something like that. So that is also not ideal. And I don't know what insurance companies' requirements are to be on hormone therapy, because that's another thing that sort of has been a sticking point at times where they will require it. Now, I think we've gotten around that because I've seen that a lot in my transgender male population, where the insurance companies had to take a step back because then they were prescribing, in a sense. They were saying, you need to be on hormone replacement therapy, which may be a medication therapy, or on testosterone, which may be a medication therapy that that patient doesn't want or that is not recommended by their physician. So early on, when they were covering surgery, they used to say you have to be on testosterone for a year, for example, for a male patient. And within about 6 months or so, they stopped saying that. So I don't know if they would be pushed back from that. It depends on the policy and how it's written.
Great.
So yeah, how to fight with insurance companies would probably be a good something to talk about.
Yeah, it's on our list.
Yeah. Basically, when I see a patient, I have a conversation with you. I will find out what your concerns are, what size you're currently wearing, whether or not you've had a mammogram, evaluate whether or not you should have a mammogram. I will examine you and see what your breast size is, and also talk about what your desired breast size is. If you're an A cup and you want to go to a C cup, or if you're a B cup and you want to go to a D cup, or however that looks. I'll also evaluate whether you have any drooping of the breast to see if there is a breast lift needed as well, in order to get you the best results. And then once we kind of have gone through that conversation, I will have you try on different implant sizes. I have a whole drawer full of implants, and some of the people in this chat have seen them. And you can try them on under a loose fitting or a stretchy bra rather than a padded bra to see what size is going to feel right for you. Corinne and I were talking earlier about the different sizes of implants. So I'm just going to use 350 as an example. If someone picks a 350cc implant, there are about 5 different 350cc range implants that I can choose from, and they're different in their profiles. So if someone picks 350 cc's, but they have a broad chest, then I'll pick a lower profile implant, which will have less projection, but have more spread across the chest. Similarly, if someone is narrow chested and they want 350 cc's, but that'll hang off the sides, I'll pick a high profile implant because it'll have a smaller footprint on the chest itself. Once we've decided our implant sizes, we will schedule surgery and kind of use those implant sizes as a basis. Before we schedule surgery, if it is going through insurance, then we will send a letter to the insurance company. Typically, they need my letter as well as a letter from a mental health professional saying that you meet WPATH criteria for top surgery. Be careful what your letter says. I had one recently that said that a transgender male required breast augmentation, which was completely the opposite of what that person required. So be careful of what the letter says. And they also usually want a letter from a medical doctor if you're on hormone replacement therapy. So once we have those 2 letters in hand, then they go out with my letter as well as the photographs that I take in the office. And then we wait for the insurance company to come back to us. Once we hear from the insurance company, if it's a no, we do an appeal. I automatically appeal every no for these cases to find out exactly why. I just want to make sure it's not that we missed something, that they say they didn't get a specific letter, or that, sometimes it's not a covered benefit. So it's always best to check with your insurance to see if it is a covered benefit.
Yeah, I think that's something that people need to know that they can ask for with your insurance company, is that you can ask as a policyholder, it's your right to get their detailed documents and what they do and don't cover under your plan around, gender affirmation surgeries and how they deal with gender dysphoria in general.
Right. Hang on one quick. Okay, sorry, my daughter's dog was acting really strangely. I want to make sure everything was okay.
Okay.
Sorry for that interruption.
So there are a couple questions that just popped in.
Yes.
So one is, and Adeline, we'll come back to your question, the first question here in a few minutes here, I think. But, so if your breasts are, for example, off to one side, or again, that gets into that asymmetry, do you have the ability to make some adjustments, where, a larger implant on one side, smaller on the other, things like that?
Right. So from the asymmetry, from a size perspective, yes, we can do different size implants. From the rearrangements of breast off to the side, that is difficult. It depends on the nipple position. And that's something that I would have to address case by case, depending on a person's anatomy. One of the challenges that a lot of trans women have is that the anatomically male nipple position is usually lateral compared to the female nipple position, which is usually more central. And it's very difficult to change the nipple position. So if they're pointing in a specific direction and you make them bigger, they're going to be bigger and still pointing in that direction, which also happens with cisgendered women. I'm not saying that it's across the board. So that's something that we discuss very carefully as far as what can actually be accomplished with just the breast augmentation. If there is, and it also depends on if there's loose tissue. For example, I've had patients who have had massive weight loss. So they have basically what appear to be very droopy breasts to start with, but they're very small. So all of that extra skin has to be removed and rearranged, and we do a breast lift as well as an augmentation. In the case of a breast lift where there's all this extra skin to work with, yes, we have more play on being able to centralize the nipples more, and move things around. The breast lift, though, is never covered by insurance.
Yeah.
We've tried and tried, and
I think it's another good thing to think about is that, I certainly, as a trans woman, sort of feel a lot of this pressure, like, you should have like the perfect female body, right? We have this all idealized image in our mind, but the truth is that, cis women feel that exact same pressure to have these perfect bodies.
Right.
And, really in many ways, our bodies are perfect the way they are. You may decide that you want to modify it or change it a little bit to make yourself more happy, but, there are some limits to what we can and can't do. Yeah.
Right. Yeah, there are. And that is something that when I sit down with a patient, I'll talk to them about their individual breast size, shape, symmetry, and what we will do. There was a question about the volume numbers per breast or total, and I'm not sure that I understand what that question is.
So I think what they're saying is, like you mentioned, 350 cc implants.
Oh,
right?
that's a single implant. Yeah.
Yep.
So,
and you may want to take some of these questions. I'm going to caution folks that it's probably going to be very difficult for Dr. Wahhab to do an individual consultation in this type of environment. So we may not get to all of these sort of individualized questions. And I'm sure that Dr. Wahhab would be more than happy to have a consultation with you. But but this idea of under muscle or over muscle, and maybe you can talk just a little bit about what the operation actually looks like.
So the operation is done under general anesthesia. I'm usually at Lehigh Valley Hospital, and more recently there's a surgery center, Surgery Center of Allentown, that I'm going to. I've done a lot of work at Lehigh Valley Hospital, 17th and Shoe Street. I've been there for almost 20 years. And so I've done a lot of work with speaking with the staff and training the staff and making sure that everyone is on the same page when it comes to respect for any of our patients that may have different lifestyles than they are used to seeing. So I guess that's the kindest way I can put it. So Surgery Center of Allentown is a new entity for me, so I am certainly going to work with them as well. I do not want people to come in and feel uncomfortable and feel judged. I've had too many patients be scared about even approaching a hospital or a medical practice because they are transgender, and that's just horrifying to me. So I made it very clear to the staff there that, you know, these are the things that we're going to follow. So my surgery's done there. It is outpatient. So you come in, I see you before surgery, I mark you. The incision is generally a small incision underneath the breast, kind of in the fold where the bra line is. And then the implants I typically place under the muscle. There are some cases where I can put them above the muscle. The downside to above the muscle is that the implant edges are more obvious, especially in someone who doesn't have very much breast tissue. And there is also a higher chance of something called capsular contracture, which is scar tissue that can form around the implant. Everyone gets some form of capsule around the implant. Whenever we put something into our bodies that doesn't belong there, the body responds by making a little scar around it. And we call it contracture when that scar, instead of sitting nicely around the implant like this, starts to kind of go like this and squish the implant underneath. And that can be uncomfortable, and it can also distort the implant. So we don't want that to happen. So putting the implants under the muscle is safer that way. I have found that in trans women, the under the muscle placement is more uncomfortable, or some people will call it painful, especially for the first week or two. And that is because the pectoralis muscle is just far more developed. So I'm stretching that muscle and I'm putting an implant under. I have also found, I mean, and that's not everyone, right? I had a trans female patient just 2 weeks ago that didn't even take a Tylenol. She was completely fine. So it really depends on the amount of muscle development that is there and how much stretch and how big the implant is too. You know, a 250cc implant is going to hurt less than a 500cc implant, or larger. But that's all temporary and that goes away. Sometimes people feel like they're not going to get out of that, but that is definitely temporary and it goes away. And then once everything is settled, it feels good.
Maybe you could talk a little bit about, so you mentioned, you know, contracture and encapsulation. I'm sorry, forget the term now, but, you know, where, you know, scar tissue may form abnormally. And, you know, what is the rate of that type of complication?
It's low. There are things that I do during the procedure to help prevent that, such as meticulous hemostasis, which means making sure there isn't extra bleeding, not washing the implants in certain chemicals and solutions. But there's also things that you can do afterwards, such as breast massage, compressing them, moving them around. There are some people that are just going to get it regardless. I had a patient many years ago, probably about 18 years ago, who came to me. She had had breast augmentation done elsewhere. 2 years later, she developed a capsular contracture. The same surgeon took her back, redid everything, took out the scar tissue. 2 years later, she presented in my office saying, I have a capsular contracture again. I said, well, we can do it again, but you might be back in 2 years with a capsular contracture again. It just might be what your body is doing to that implant. So it's really, it's something that's difficult. It's not very common. It's only probably about 5 to 10% of people will have a capsular contracture that's significant enough that they seek treatment for it. You know, there's
so for example, I developed keloids. Is that an indicator that, you know, that type of thing would happen more often? Okay.
No. I mean, that is a potential for having worse scar on the skin, but that doesn't have anything to do with any scar on the inside. So then I have you wear a bra. Those are bras that you actually pick up in the office, and you bring one of them with you to the operating room. We put it on right after the surgery. I see you 2 to 3 days later. I remove the bra, remove the dressings, check everything, and then that's when you're allowed to shower. For the incisions, you can use antibiotic ointment. You can use a product that we sell in the office called Shield Recovery Balm, which helps with the healing and less scar formation. And you can also do laser scar treatment, which we also offer in the office, that helps with the scars. Nothing will erase the scars. However, I can say that those scars, once they're well healed and well cared for, are many times less obvious than just the marks from your bra when you take off your bra at night. They heal really nicely underneath the breast. We do put you on antibiotics. I do give you pain medication, obviously, and antibiotics for a week. I see you usually 10 to 14 days after surgery to snip the little ends of the sutures. And the bra needs to be worn for 6 weeks, day and night, and no heavy lifting for 6 weeks. Other than that, most people anywhere between 10 days to 3 weeks are feeling up to doing most of their normal activities. And then I usually see patients close to a year after surgery to evaluate everything, make sure you're happy. And of course, I'm always available in between, right? If something comes up in between, I'm available, you can see me anytime. We can't talk about surgery without talking about risks. So do you want me to answer some questions, or do you want me to talk about risks?
Well, let's do risks first, and then we'll try to,
okay, because
that might answer some questions.
Okay, so I see a lot of things from Emma. Thank you, Emma, for all of your comments. Risks like any surgical procedure include bleeding, pain, infection. The hospital's pre-printed consent form is going to say stroke, paralysis, and death on it. Very scary. No one wants those things. I always tell patients you have a higher chance of getting struck by lightning than having stroke, paralysis, or death from an elective procedure if you're healthy. I don't even say young and healthy anymore because there are a lot of young unhealthy people. So, and there are a lot of older healthy people. So as long as you're healthy, the risks should be very minimal. Other risks include loss of nipple sensation, altered nipple sensation, unsatisfactory size or cosmetic result. And the way I try to mitigate that is by having you try on implant sizes and deciding what's going to be the right size for you. If I choose your implant, it's going to be what I think will look best on you. And that's completely irrelevant if that's not what you think will look good on you. That's always been my philosophy on that. Corinne and I were talking earlier about sort of the paternalistic view of surgery, where a lot of surgeons will say, well, this is what you need because this is the size that will fit on your body. Well, that's irrelevant. I mean, all bodies come in different shapes and sizes. There are skinny women with big boobs and heavy women with small boobs. I mean, it's not necessarily something that looks, it's in your own eyes, right? It's what you want to see for yourself, not what you want others to see of yourself. Capsule formation, which we just talked about, those are all of the risks for the most part, all of the major risks. It's very rare that an implant from an augmentation becomes infected and has to be replaced. You do need to be aware that implants can get infected anytime. So in 10 years, if you have a really bad infection somewhere else in your body that's getting you hospitalized, that can travel to your implants as well. But it's not common enough that anyone needs to be put on antibiotics for dental cleanings or anything like that. It's extremely uncommon to have a delayed infection of an implant, but it can happen.
What about having to go back for revisions at some point down the road?
So we can never say that an implant is a permanent implant. We can't say that about anything we put into a body, including a knee replacement or a hip replacement. But there is no timeline. There was for quite a long time. It's finally starting to dissipate. I call it plastic surgery urban legend that implants need to be replaced every 10 years. And that was started, I'm convinced, in California by some plastic surgeon who was looking to, keep having people come back, because back in the 90s, 2000s, the implant manufacturer warranties were 10 years. So someone had the bright idea that if the warranty is out in 10 years, we should just change them every 10 years. And that got so big that it actually became a question on our plastic surgery boards, because they wanted to make sure that because a lot of plastic surgeons felt that way. They were taught that this is what you're supposed to do. So they don't need to be replaced on any kind of schedule. They only need to be replaced if there's a problem or an issue. I can tell you the most common replacement issue is usually size, someone deciding they want to be smaller or bigger. They do come with a lifetime replacement warranty, which means that they will replace the actual implant, but for the first 10 years, they'll also pay costs towards surgical fees. I've seen implants that have been in for 30 years that are fine. I've seen others that have been in for 5 years and they're ruptured. So it's really variable.
Well, why don't we try to work through a few of these questions here. So I'm going to kind of scroll up and I'll just read them off to you, and we'll do like a quick draw here. Okay.
Sure.
So here's somebody they say, they have a large chest, they have a 54-inch chest, and their comment is, they probably would need a low profile implant.
Mm-hmm.
So I guess there's confusion around, so you can be a C cup with a low profile implant. You can be a C cup with a high profile implant, right? It's just a matter of.
So the cup size is all going to vary depending on what the amount of original tissue there is. So if you put a 350 cc implant in someone with an A cup, they may go up to a C, but if you put it in someone with a C cup, they're going to go up to a D or a double D, right? So it really depends on what the starting size is. And then the implants range from, the smallest implant is 150 cc's, and the largest implant is 750 cc's. I think there's an 800 cc implant out there floating around, which might be a saline implant. So there's a really wide range. So it would be a matter of deciding what size is going to work well, and then finding the right profile for that size. And there are measurements that can be taken and things like that and compared to the implant sizes.
Yeah. But the most important thing is that you want to have a surgeon who's going to let you try on different implants so that you can find what's comfortable for your body.
And tailor the procedure for you. I had one woman who came to me who had surgery in Arizona, who had, I feel like it was 450 cc implants. And she said, basically her surgeon said, this is what he puts in everyone. This is just what I use for everyone. I'm like, that makes zero sense, right? Like 0 sense when there are so many available. I said, what do they do? Fall off a truck? Like, he has all these implants laying around. Yeah. Because you can't use the same implant for every person. It's just impossible.
So here's a question around mammograms. So do implants interfere with the reading of a mammogram?
They can if you get calcium deposits around a capsule. So when they're reading mammograms, one of the things that they're looking for is microcalcifications. Microcalcifications are like the size of glitter. We all know what glitter is like. And macrocalcifications are what can form around an implant if there is a capsule. And those are basically the size of confetti, pieces of confetti. So basically that piece of confetti can cover up that little piece of glitter that they're looking for. So oftentimes with implants, if they can't see something or if there's something blocking, they'll do additional views. And so they may, sometimes women have to be called back for additional views. And also, if they can't see it, then they can recommend an MRI, which will definitely pick up any kind of breast cancer.
And it should be said that, being called back for a second look at a mammogram is not uncommon.
It's not uncommon at all, even for women without implants, because it depends on the density of the breasts. And a lot of times it's just, we can't, usually a second look is we can't quite make something out. We want to make sure that we're taking a good look at it. So it's not necessarily a negative thing.
Okay. So I know that for bottom surgery, a lot of surgeons have restrictions on what your BMI can be before they'll do surgery. Any restrictions that you're aware of around top surgery for this?
I personally don't have restrictions, but I'm not the same as a lot of other people. A lot of surgeons will have restrictions. I think some of those restrictions, quite honestly, are because the higher the BMI, the more difficult the surgery is, and the more difficult it is to get what they would consider to be a good result or a picture perfect result. My feeling with patients with gender dysphoria is I almost feel like it's prejudicial to say, well, you have to, be an ideal BMI before I'm going to do your surgery, because some people are just not going to get there. They're just never going to get there, and they're going to be stuck in this shape that on top of it they don't like, and that's causing all this dysphoria. And I see that quite a bit with my male patients, because the result is not going to be perfect. But as long as the patients are aware of that, then I'm fine with it. One of the difficulties in female patients for breast augmentation who have a very high BMI is that I then have to look at what the chest tissue looks like and what the breast tissue looks like and try to make a determination of if we have an implant that's going to fit and work well. And whether there needs to be, oftentimes with a high BMI, there's also some breast ptosis or drooping. So then the other question is, do we need to do a lift as well, which is a cosmetic procedure? Because if we put an implant in and then the breast tissue just kind of falls off the implant, then that doesn't look good either. So, it's about having conversations about what your expectations are, and what I can actually deliver.
So really important to ask, lots of questions, right? And take your time. It's okay to shop for a surgeon too. I think that's important to know.
Don't have surgery with someone you're not comfortable with, and don't have surgery with someone who doesn't treat you with respect. I've seen that too often, and then I've seen people have come into me for revisions or different things, and they'll say like, I didn't like this person. Then don't let them cut you if you don't like them. You have to have that rapport.
So here's another question. This one's maybe a little bit specific, but somebody said that they've gotten a pre-author approval from their insurance company. They didn't actually have to submit pictures in their particular case. And the question is, does that mean that they've already gotten through the approval step, or is there a risk that they're going to have to do some more?
I don't know the answer to that question.
Okay.
Without having seen the letter that was sent or the letter that was received, I don't know. If the insurance company says that, usually in the authorization letter, it'll have the physician's name, it'll have the facility number and name, and it will say you've been authorized for this following surgery. They always have a disclaimer on it saying that it's not a guarantee of benefits. So I would ask the surgeon's office what kind of letter was sent and make sure that they say that it was pre-authorized. That's a tough question. I have not had an insurance company send an authorization without pictures.
So worth investigating.
But there may be some insurance companies that don't require them, and that's quite possible.
And that would be a good thing.
Yeah.
So here's a question that we got in a private chat, just around, and I know I've had this happen to me in the hospital around misgendering and people acting inappropriate around trans folk. And you mentioned earlier that you really work hard around trying to educate staff, but maybe you could talk a little bit about what actions you take to try to improve that experience for trans folk in the hospital.
That I personally take?
Yeah, or that as you work with your staff. And
well, we always, luckily my staff in the office is very small. It's just a couple of people and I'm the boss. So I can get rid of anyone I don't like. But everyone is great. We had difficulty. We had a woman in her, and she's not that old. She's my age. She's in her 50s, and she kept having trouble with misgendering people or using their dead names. And, I finally sat her down. I said, look, it's like if someone walks in and you call them the N-word. It's such an insult. You have to stop doing it. And she said, I'm sorry, but this is what's on the paper. And I said, you have to figure out a way to stop doing it. She ultimately left our office for personal reasons. She had an ill mother. But I'm sure with time, I would have gotten her there. But as far as the hospital staff, I've had a couple of different meetings with them, educational meetings, to go over everything. I have, the hospital has now started to finally put in preferred names on the medical record, which is really helpful because then people can look at that. I'm always in conversation with my staff in the hospital about different issues, and they also know. They know two things. One, they know that I'm very strict about certain things. So they want to make sure that that's all good. But the other side of it is they know that I'm very open to conversation. So if they need to know something, they can ask me. So for example, I had a nurse anesthetist and I had a non-binary patient. And this nurse anesthetist, when she went to talk to the patient and the patient's mom was there, said, oh, does he need to use the bathroom before he goes? And the patient was very upset and said, I am non-binary. And the nurse anesthetist was very flustered and she came back and she was talking about it. And she said, well, I'm trying so hard to do the right thing. And like, to me, like, this is a person who has breasts and is having a mastectomy. And I was trying so hard to do the right gender by saying he, but then I got, in trouble for not saying they. And she's like, I just don't know what to do. And I said, it's really easy. I said, all you do is say, what are your pronouns? When you go see the patient, say, what are your pronouns? And then do that. And it's funny because she loved that. And then she started using that. And she said everyone was very happy about that. And then a couple of months later, she said, I always say, thank you, ma'am, and yes, ma'am, and no, ma'am, and sir, and whatever. So I don't know how I'm going to do that. And I said, well, say, thank you kindly. If you want to add another word, say thank you kindly, or say, yes, please, instead of yes, ma'am, or that sort of thing. So, there, a lot of times people are trying, but they're just not used to it. But I don't accept that as an excuse. So I always try to find a different way for whoever it is that's asking me these questions. I try to find different ways that they will feel more comfortable with the language, and they can kind of start taking that gender piece out. I had a nurse who asked a patient who was trans male if he needed to use the ladies' room. And I just saw the look on his face, and I was like, it's just a regular bathroom. Why do you have to call it a ladies' room or a men's room? It's just the bathroom, So trying to just always work with people on these conversations. And we're always, I see a lot of transgender patients, and I do surgery on a lot of them. And so my staff is just used to it. And anyone who's new, we just have conversations, and I just kind of keep the conversation open all the time.
All right, well, let's get back into the technical stuff. So saline or silicone implants, do you have a recommendation?
So I usually use silicone implants. I find that they are far more natural feeling and looking. I will use saline implants as well. So it's patient preference. There is a new saline implant on the market that is very similar to silicone. It kind of mimics silicone in its softness and the way that it moves. But that implant can only be used for cosmetic cases. The hospital doesn't buy them. So that's something that we could discuss in consultation if someone is worried about silicone. A lot of the worries around silicone are because of the 1980s with the Dow Corning lawsuit, where women had ruptured silicone implants and there was silicone leaking around their body and silicone found in lymph nodes. There was a huge study, right? I mean, silicone implants were pulled off the market for 10 years. There was a big study with the FDA. New England Journal of Medicine published a huge study on the fact that none of those symptoms and problems were actually related to the silicone. And even I actually had a patient whose uncle was on the jury for that trial. And she told me that he said, none of us really felt like it was the silicone, but we felt bad for these women and we wanted to give them some money, which was kind of like baffling to me because it really caused a big problem. So the current silicone implants are more of a cohesive gel. So a saline implant is basically water in a baggie. Poke a hole in it, it leaks out, it goes flat, that's it, you're done. It's gone. The old silicone implants were like pudding in a baggie. You poke a hole in it and it kind of oozes out. The new silicones are like fully formed jello that were put in a baggie to form. You poke a hole in it and it kind of stays where it is. I mean, yes, there's a hole, but the jello doesn't kind of ooze out the way the pudding used to, the old silicone implants. So I do believe that they're safe, but there's also another big issue out there, and there's a large group of women, and if anyone wants to look it up, it's called breast implant illness. And they are lobbying with the FDA to do more studies and to get to the bottom of this illness. It is ill-defined. I think there are 87 symptoms. There might be even more at this point. And so there are a lot of women who are fully convinced that their silicone implants are giving them problems. Having said that, I've had several women come to me with breast implant illness symptoms that had saline implants. So the outer shell of both of those implants are silicone. The outer shell is the same. It's silicone on the outside. One of them has salt water on the inside. One of them has silicone gel on the inside. Okay. And I don't know if breast implant illness exists. I'm not saying it doesn't. There are a lot of plastic surgeons that will say there is no such thing. I believe that if hundreds of women are having issues, it's something to be looked at, but there hasn't been anything scientifically proven yet.
Okay. How about, let's talk about incisions. So under breast, under the armpit, through the nipple.
Under the breast.
For trans women, or that's just your preference?
Yes, no, for all breast augments. The issue with around the nipple is that it's very limited in the size of implant that you can place, and that scar is always visible. You look in the mirror, you see the scar. It's right because it's right there. The transaxillary incision has actually gone out of vogue, but one of my problems with it even early on was that you see it in a tank top. I mean, it's an incision right here. And as women, we wear bathing suits, we wear tank tops. You're going to see that scar. And there's a private question here, or maybe it's not private. It says to all panelists, but I'm gonna read this because I think this is really important. The scar that goes under the breast has the best access. If you have to do a revision, you can use the same scar. With the transaxillary scar, the one in the armpit, you have to go under if you need to do a revision. If you get into bleeding during the surgery, you end up having to convert. Now you have two scars. The under the breast one just heals so nicely and so invisibly. You had one patient tell me that the only living being that saw her scars was her dog when she got out of the shower, and the dog is looking up at her because they're really, and yes, so if someone is a stripper or a pole dancer, or does a lot of topless under, from looking up from under, you may notice it, but other than that, it's really not noticeable. You don't see it in a bikini top, anything like that. So hospital staff misgendering, there was a question about what we can do to mitigate the sort of thing happening in a medical or healthcare setting, especially with gender affirming surgery. So we have been working, there is actually a person who is in charge of cultural diversity at the hospital. And she has been doing a lot of work with the LGBT to healthcare initiatives at Lehigh Valley Hospital. It's not perfect. It's not going to be for a long time, unfortunately.
I think it's important to say we have people on this call from as far away as California, I know for sure, and maybe even Alaska. So the key is that this is an item that most hospitals are aware of in one way or another. I know that we locally, we work with the two large hospital networks locally pretty frequently around these types of issues. And if somebody has an issue, we want to know about it so we can raise that issue with the hospital networks. And we're getting involved with a third one actually. But most hospitals now have diversity, equity, and inclusion officers, and absolutely bring those things up when there is an issue. And
yeah, I think that unfortunately, when people are having healthcare issues, and then they are misgendered, or they are made fun of, or they are dismissed because they are transgender, or because they are gay, or because of anything, or because they're Black. I mean, any host of things. The initial instinct of the patient is to retreat because they're in a stressful situation, and that's understandable, right? So their initial instinct is to retreat, to go away and say that I can't go there again, or whatever have you. And I think that that's okay for that small time being, but then you need to come out and call the people, call the diversity people, call the, go as far up the ladder as you can, call a patient advocate, and get on them about it and make sure that it gets taken care of. And I am not a big one on posting things on social media to call people out, but if it gets to that point where you can't get anywhere with it, post it on social media anonymously if you have to, because once it gets out there, that hospital is going to have to make some changes and is going to have to get fixed. Whenever I see people who say anything, even if I've overheard something that someone else is saying, I will pull that person aside and talk to them, or I will report them to their supervisor. I'm not taking it, you know, and you need to find those people in your communities that are going to stand up with you, because it's very hard to do alone.
So another technical question here is, so if you've been diagnosed with dense breast tissue, is that an issue around getting implants?
No, it's not.
Good.
I would like to say also, if any of my patients have had issues, please let me know. Give my office a call, send an email, however you want to do it, so that I can research who it was that was taking care of you and address those people directly.
Great. There's a question here. Let me get back to it. Scarring associated with getting a lift?
Right. So the scars associated with getting a lift are significant. It's around the areola and then a vertical line down the meridian of the breast. I'm going to demonstrate on myself if that's okay. So it's going to be around the areola, vertical line down on the breast, and then in the crease underneath. That is the most common scar for getting a lift. Again, can be treated with laser scar treatment and with skin creams, but it is going to always be, that's going to be very visible. And that will always be visible. It'll fade to sort of fine lines, but there will always be visible scarring on the breast from that, yes.
Okay. A question about smooth versus textured implants?
Textured implants, you know, the benefit to them and the reason for them was to make sure that they stay in place. The texturing almost acts like a little bit of Velcro, where the body will grow into that and it'll keep the implants there. Textured implants have been associated with breast implant associated anaplastic large cell lymphoma, which is a very long word. It's abbreviated BIALCL. So it's a type of cancer. It's a lymphoma that can occur around textured breast implants, and it has only been seen around textured breast implants. They are still researching if it's a specific manufacturer's textured implants, all textured implants, but as a result of that, we're really getting away from textured implants. I will occasionally use textured implants in breast reconstruction patients because there are some teardrop textured implants. They can also be used in augmentation, but we're really getting away from them because even though this is a very, very rare disease, it's very easily treatable if it's recognized right away, it's still very devastating. So we're getting away from textured implants right now. That pendulum might swing back.
Okay, great. Maybe you can talk a little bit about the recovery process and what that looks like.
So the recovery afterwards, everyone is different. I've seen a few comments in here where one person says they were great in 2 days and someone else might say it took a good 2 weeks. I would say on average, so the no heavy lifting, like 25 pounds for 6 weeks. On average, people are on pain medication for probably about a week, sometimes a little less, sometimes a little more, and up to doing most normal activities within a week to 2 weeks. Okay. Unless your normal activity is doing 50 push-ups in the morning, like they're not going to be doing that yet, other than the lifting.
And wearing a surgical, so I have a friend who had surgery down in the DC area, and actually her surgeon said you don't need to wear the surgical bra afterward, just, you know, let them hang. Which shocked me, actually. So
yeah, so that's interesting. I always refer to what I call the Miami experience, which is young girls having breast augmentation anywhere between the age of 18 and 22, and then living on the beach in bikinis all day and playing volleyball. And then by the time they're 30, their boobs are down to their belly buttons. So I would say, yeah, I mean, you can let them hang and that's fine. I advise a surgical bra for 6 weeks. And after that, I advise that if you want to maintain them, you should wear a bra most of the time. Because gravity is going to have an effect, and it depends on your age as well. I mean, if you're 25 and having this done versus if you're 65 and having this done, there's going to be a difference in how much they change over time, right? If you've had implants for 40 years, they're going to look a lot different if they're not supported in some way along the way.
So other than wearing a bra most of the time, and I'm assuming that doesn't mean when you're asleep.
Correct.
But most other times, wearing a bra most other times. Anything else in terms of, helping with scarification and things like that that folks can do?
No, not really.
Somebody mentioned Shield Balm, I think, up in the
Yeah,
chat.
that's the recovery balm that we have in the office.
Okay, great. Well, let's see here. I'm not looking to see if there's any other questions that are like really that I might have missed here. General cost if insurance doesn't cover. There's a good one.
Yeah, I think it is around $7,000, which includes the implants, hospital, anesthesia, and my fees. It might be less. It might be like 6,500. I do not remember off the top of my head.
And does that is that impacted at all in regards to age or the size of the implant or anything like that?
No. The only difference would be if there's a lift involved.
Okay.
Then there will be more fees. The hospital and anesthesia charges by time. I charge by procedure. So I kind of evaluate and decide about how long I think it'll take to do the procedure, but I'm not going to charge someone more because it's going to take me longer to do it.
Okay. So actually somebody just asked, what is the cost of a lift? So.
So a lift and implants?
Sure.
I don't know. I don't know. I can probably pull someone up and see, but I think a lift without implants, including hospital and everything, is somewhere around 6,000. And I know when we do a combination, we kind of like condense the price a little bit. Okay. So I would say it's around 10 or 11,000, but I can't be 100% sure.
Okay. There's a question about, well, let's just stay on cost. Somebody wants to know if there's a refer a friend discount or a group discount. So if we just get a consortium going.
Yeah, I can't do that. There are a lot of sort of rules about that because of physicians, because they don't want physicians to refer to other physicians and get a kickback. So I can offer a really big hug and a thank you, but I don't like to get into that sort of murky water because of the other things that it can kind of come around.
It creates ethical issues.
Yeah.
Restrictions around exercise. So obviously during recovery, there's restrictions around exercise, I'm sure, but what about afterward?
Afterwards, anything goes. I mean, I have patients who are, they do full contact sports and taekwondo and things like that, and they're fine. Now, I will say that if an implant is hit just the right way with just the right amount of force, it can rupture. So I had a patient, for example, who was in a car accident, no broken ribs, no trauma, but the implant was definitely ruptured as a result of the car accident from the force, I think, of the seatbelt, the way that it hit. So there are some blunt forces that can cause that. I had a patient who was kicked by a horse, another patient who had a 170-pound dog jump on her chest. So there are some times that like a blunt shock, it's kind of one of those things that you hit the sweet spot and it's going to go. And of course, anything sharp. So why would you have something sharp in your breast? Breast biopsies, and obviously fractured ribs from accidents.
Yeah. So obviously it's important to make sure that you're informing your other doctors about the fact that you have implants.
Yeah.
The length of surgery for, a typical top surgery?
For a breast augmentation, it's just straight up breast augmentation is typically an hour.
Okay. So an hour under anesthesia, but you got the prep time and the recovery time.
So the time in the actual hospital is closer to 4 or 5 hours because they want you there an hour and a half to 2 before. Then there's getting you to the OR, putting you under anesthesia, waking you up, recovery room, and then recovering even further to go home. So I always tell patients to plan to spend a good half a day there.
And so here's a question. I know it comes up a lot that, I know when I've had surgery, I've had to come off my estrogen for a period of time because of concerns around clots. But what about Coumadin and other blood thinners maybe you're taking for blood pressure?
So blood pressure medications are okay, but any kind of blood thinners need to be stopped before surgery. Anyone who is prescribed a blood thinner, I will have them get clearance from their medical physicians. In some cases, they are allowed to be on injections until the time of surgery and then off. There are going to be, some cases like mechanical heart valves where those patients are going to actually need to be admitted into the hospital put on heparin, taken off heparin just for the surgery, and then put right back on it. But most people who are on prescription blood thinners will be okay with outpatient management of injections for the like enoxaparin and those kinds of things. Other blood thinners that people take and sometimes don't realize are blood thinners are things like vitamin E in capsules. Vitamin E in a multivitamin, that amount is not considered enough to do anything from a blood thinning standpoint. But if you take a vitamin E capsule separately, or fish oil, krill oil, those kinds of things can thin the blood. Garlic capsules, which were really in vogue about 5 or 7 years ago. I don't hear a lot of people taking them anymore.
Okay. Question about, can you drive yourself home from surgery?
No, definitely not. And you need to have a responsible adult with you for the first 24 hours. So you can't Uber home either.
Yeah. There's a question about how long after HRT begins should you wait for breast augmentation? I know this is controversial sometimes.
Yeah, that's controversial. So there are two parts to that. One is how much breast development you're going to get and how long that'll take. And the other is overall emotional state. So I don't, and having a new medication. So I don't ever advise anyone to start HRT and then have surgery within 6 months or whatever, because you want to make sure all of your levels are stabilized and everything is good. And there are a lot of emotional responses, and sometimes people will feel like their emotional response is going to be just extreme happiness. And then they're upset when that's not what it is. So I want to make sure everyone's emotional well-being is in the right place. And I think hormones, whether it's estrogen, spironolactone, progesterone, all of those things, or testosterone, they all affect your emotional well-being. So there are some doctors that will make people go off of their hormone therapy before surgery. I personally do not agree with that. I've done a lot of research that says that that's not necessary. I think that sends patients into a little bit of a tailspin, and I don't think it's healthy for your mental health. I also worry/wonder if some of those physicians are just not familiar enough. And so it's something that is unknown. So they would rather say, just go off of it. So that also concerns me. But there are increased risks with certain things like blood clots, and there are things that can be done to mitigate those things. If you're on HRT and you're a smoker, you're going to have a higher chance of getting a blood clot. And so we have to be very careful, and you have to be careful. And I would advise you to quit smoking, those kinds of things. Whether you're having surgery first or starting HRT first, I would maybe give a span of a good 6 months in between, and make sure whichever thing is happening is kind of leveled off and everything is good.
Yeah, there is a risk of if you do surgery too early in your HRT regimen, that you can continue to have breast. I think you mentioned this earlier. You can continue to have breast growth, right?
So that was, so the second part was the breast development. So I sort of got on track of the mental development and lost that part. So, they say that after you've been on for a minimum of a year, you're kind of getting pretty close to where you're going to end up. Some people say 2 years. I think everyone knows their bodies. If you've been on for a year and you said, this is where it is and it's not going anywhere further, then I'm fine with moving forward with surgery. If you want to wait 2 years, that's fine too.
Yeah, great. Well, we'll wait another moment or two just to see if there's any other kind of additional questions, but I think we hit just about everything that came through the chat, and everybody was really involved, so that's pretty cool.
One person did ask about baby aspirin. So baby aspirin, I think, is fine for surgery, but there are a lot of surgeons that will tell you to go off of it. And it also depends on the surgery. If someone was having a facelift, I would say no to the baby aspirin. If someone was having like a more extensive, like a tummy tuck or something like that, I would say be off of the baby aspirin. For breast augmentation, usually I'm okay with that. It's usually pretty bloodless. But again, it's going to depend on your body type. If there's any other factors that may increase bleeding. So that's the answer to baby question. How long to wait for? Okay, so I would say 2 years for maximum breast development after HRT. If you're looking for max, I don't think it's going to go anywhere after 2 years, but for most people, it's a year.
Yeah. So one person said that they're still getting some growth after,
Yeah.
3-4 years. But I think that the most important thing, and this is, I know you brought this up several times, is the real importance of really having a good consultation with your surgeon, right? And I see somebody actually just asked, what is the charge for a consultation? So that's probably a good time to address that one.
Right. So if you're coming through with insurance, we go through your insurance, and so whatever your copays are. If you're coming through without insurance, it's $100 consultation fee, but that is taken off the cost of your surgery.
Okay.
So if you have surgery, it ends up being a free consult.
There you go. And again, just really making sure that you spend good time in advance with your physician, whether it's you or anybody else, just really making sure that you feel comfortable with what's going to happen. You understand the risks, you understand what recovery looks like, and things like that are very, very, very important.
Right. And if anyone doesn't answer all of your questions or doesn't give you time to ask questions, then that's not the person for you. And also, I have to say, anyone can have a bad day, right? Anyone can have a day where suddenly things are running late and you're kind of in a rush, and maybe I'm not giving you the attention that you need, but you can always give them a second chance. But if after 2 times you're not liking it, then yeah, find someone else.
Perfect. Well, really want to thank you so much for your time tonight. I really appreciate it.
You're very welcome.
We do hope to have you back so you can talk to the trans guys.
Of course.
And I know that we have a couple of your satisfied patients on the call tonight, so that was kind of fun as well.
Yeah.
And we look forward to having you again. For all the people that are on the call right now, we will have a recording of this up on our YouTube channel in about 3 days. Give me a little time, and for editing. And you just search Eastern PA Trans Equity Project on YouTube, and you'll find us. So thank you all. Thank you very much, Dr. Wahhab. You're awesome.
Very welcome. It was a pleasure. I hope I was able to answer some questions and give out some information.
Great. Thank you so much. Good night, everybody.
You're welcome. Good night. Thank you.
Bye-bye.